Welcome to Public Health on Call, a new podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, a faculty member at Johns Hopkins and also a former health commissioner in Baltimore City. Until recently, our sole focus has been COVID-19, the global pandemic. We are broadening the podcast to other urgent public health issues. Today, I'm speaking to Dr. Georges Benjamin, Executive Director of the American Public Health Association. Dr. Benjamin is one of the most trusted and experienced leaders in the field of public health. We interviewed him a while ago on the COVID pandemic. Now, we speak about what it means to talk about racism as a public health issue. Let's listen. Dr. Benjamin, thank you so much for joining us again on the podcast. Today, I want to talk to you about racism and public health. And I just want to start with a question to you as the head of the American Public Health Association. What does it mean to call racism a public health issue?
Well, we always talk a lot about what the root causes of any kind of disease or injury. And so racism is fundamentally a social determinant of health. And in many ways, it is the original sin that has resulted in a whole range of disparate health impacts. So I think public health has finally recognized that if we don't address racism at its very core, we're not going to be able to fundamentally improve health and address health inequities.
So when you think of the impact of racism on health, where does your mind go first?
My mind first goes to the fact that we treat people very differently in a variety of ways. We know that it's about access to healthcare. It's about the differences in the quality of healthcare that people receive. There's differences in the behavioral way in which people think about health. And then, of course, particularly on the mental health side, the enormous amount of stress, which we ultimately know results in a range of impacts on health, from not only mental health, but physical health.
What about the other social factors that contribute to health and racism's role in those? Say, for example, redlining leading to housing challenges, leading to problems accessing food or safe neighborhoods. How do you view that in the context of racism and public health?
So, the challenge we have is that we know that many of the negative social constructs that we have are based on racism. And so, for example, I remember after my dad died, looking through his papers and finding the deed for the house and observing the fact that the deed was stamped that the house couldn't be sold to Negroes. And it was fascinating to see that because, I live in a middle-class neighborhood. My parents and I have certainly talked about racism over the years, and I kind of had heard that story, but it didn't really hit me until I realized the fact that was a barrier to my parents, would have been a barrier at some point to my parents buying that home. And if you think about that, I had always grown up thinking that, African-Americans move into the community and then you have white flight. Whites leave. But it's, our society is structured for us to self-segregate, which is really a problem. And I grew up in Chicago, which is really one of the more segregated cities in the country.
So how do you think public health has done up till now in recognizing and responding to racism?
We have not done well. We've always believed in equity and social justice, but racism, the R word, was a word that nobody ever wanted to speak out loud. But I think there's been a real awakening around that. I remember Bill Jenkins. Bill Jenkins, some folks may know, was the CDC staffer who blew the whistle in Tuskegee. And I remember him speaking at the APHA annual meeting and, getting the 6,000 people in our opening session to stand up and say the word racism.
When was that?
It was about, I'm going to say 6-7 years ago.
And to set the scene for us, how did people respond to that?
Oh, people were excited about it. It was, in many ways, it was an awakening. In fact, you can still find it. It's on YouTube on the website. And he said, we have to call these things out. Our president, Kamara Jones, one of her first principles is you have to name racism. You have to define it. You have to call it out when you see it. And I think, at least for me, that was an awakening because, usually what happens is you have an experience that you think might be racially motivated. And particularly if you're of color, you tend to kind of mumble about it and, shrug it off unless it is something really egregious. But now people are not tolerating it anymore. They're calling for what it is. They're not equivocating over events where people have treated you unfairly. Things like shopkeeper vigilance, where they follow you around the store, or disrespect, or not recognizing the quality of what you bring to a project. And people are beginning to say, look, I'm equal and I can do this just as you can. And when it happens to others, calling it out as well.
As health departments, stand up on this issue, how is APHA supporting them? I know it's certainly an issue for schools of public health to think about how we can do better first for ourselves, but also through the instruction that we give students. How do you think about your role as a professional association? You have all these members, maybe some of whom are waking up to this, like you said, who may need some training and support to be able to do a good job. What does that conversation look like right now?
Well, we're doing two or three things. First thing we're doing is looking internally to make sure that we're walking the talk. And so we're looked at the fact that we are diverse, and we know we're a diverse staff, but we're also trying to make sure that our staff are culturally competent. So we're doing internal staff training. And then we're beginning to work externally by doing a series of webinars to educate the field and the public in general about racism as a public health issue. We did a series of 3 webinars about 2.5 years ago. And then when we started seeing a disparity with COVID-19, we decided we needed to do another series. And so we've just started doing another series on racism as a public health issue. And we're going to look at not just further defining it for people so they understand it, but looking at things like police violence, looking at issues around disparate outcomes for women, and as examples of some of the things that we're trying to really focus on, because we think now that we need to look at some of the targeted subject matter issues that result from racism.
And what's the response been so far to the series?
We had over 9,000 people on the webinar.
And is that better than the last time you did this?
The last time was about 6,000. We bought it, so we're growing.
Okay. All right. Well, that's good. So I remember in our last conversation for the podcast, it was very early on, very, very early on in the COVID situation, but you immediately called that this was not going to remain a disease of people who'd gotten back from cruises. I think that is how you put it. And that we were going to see this pandemic expose some major flaws in our society. And, I think about those words a lot with each, day passing, showing, the low wage workers, people living in congested high rises, people who are forced to take crowded buses, and, just the ways in which the pandemic has revealed the fact that some people are able to protect themselves a lot easier than other people. How have you watched this unfold through the lens of race and racism?
Well, I have to admit, while I knew there would be a disparity because of both exposure and susceptibility, exposure being basically your occupation and susceptibility being folks that have lots of chronic diseases, I frankly did not have any concept of the magnitude of that impact and the huge disparities we're seeing, not just in the prevalence of disease, but also in the mortality from that. And I got to tell you, I was not shocked and surprised. And I was also shocked and surprised that even today, we still don't have the data and a full accounting. Our systems have really failed us in terms of finding out who has it, when they had it, and how they got it. And that is a fundamental failure of public health that we have to correct. And what I've been saying basically is that, we screwed up the first 4 months. Let's not screw up the next 6.
And so what does that look like, the not screwing up part, getting the data right?
It means absolutely getting the data right, and not just race and ethnicity, age and gender, but it also means occupation, because we now know that there are occupations that are more at risk than others. And that's going to be very important, I think, as we begin doing antibody testing, once we get that right as well. When we start talking about if we ever can get a prophylactic therapy other than vaccines, at the end of the day, it's all about a vaccine. And we're going to have to figure out who do we vaccinate, what the priority is for that vaccination if we really want to get our hands around this disease. It's not just telling everybody to line up and get a shot. We're going to have to prioritize the vaccine, both because of the availability of that vaccine, as well as there's some priority populations we know we're going to have to address first.
As we think about the need to confront racism in public health, how do you see the role of health departments changing? You certainly, on COVID, like you said, there is the urgent need to get data, the urgent need to be more intensive about outreach with particular communities and design solutions that work for them, partnering with leaders. But what about more broadly? One common theme that I've heard, or common question, is could the health department take over the police department?
I think we ought to not take over the police department. I think we have enough challenges with our own police powers. I think that as the nation moves to getting rid of police departments and getting public safety agencies, and I think one thing that public health can do is help with the thinking about how do we provide people what they need when they need it. And what's happened is we've over-militarized the police. We have over-policed many communities. And, we have police officers who are acting as social workers, not trained, mental health counselors, not trained, first aid providers, not trained. And, we have to respect them. They have to have stresses. They have stressors too, but we're asking them to do too much without the skill set to do it. And if you only have a hammer, everything looks like a nail, as they said. And so we need to fix our system so that if somebody is homeless, they get a homeless counselor. If they have a mental health problem, they get a mental health person to come take care of them. If someone's inebriated sitting in their car, that 911 sends an EMS system to come get them, not the police officer. Now, there are going to be violent encounters. That does happen, particularly in domestic violence situations. Those are always very touchy ones. But then you can pull together a team. But we've got to rethink how we respond to human needs in our country. Now, public health won't lead that effort, but we absolutely can be a major part of wrapping ourselves around the health component of that.
Got it. Any other final thoughts on the role of public health in this sort of national reckoning on race?
I go back to this concept of us being a chief health strategist in our community. I think that's a leadership role. And I think public health should embrace that role. It doesn't mean that you have to do everything, but it does mean that you provide that leadership.
Great. Thank you. Thanks again, Dr. Benjamin, for joining me today.
Thank you. Glad to be here.
Thank you for listening to Public Health on Call, a new podcast from the Johns Hopkins Bloomberg School of Public Health. Please send questions to be covered in future podcasts to publichealthquestion@jhu.edu. This podcast is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Lamare Morales. Audio production by Niall Owen McCusker and Spencer Greer, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.